Hello, everyone. Welcome to our today class. Am I audible?
Yes.
Thank you so much. Welcome, everybody, to our two-day Perineal tear prevention, diagnosis, and management, and hands-on training with our scientific board from LEC, Dr. Edson, Borges, de Souza. So now we are with you from LEC, and happy to see you here, all of you. As you know about LEC, we are a multinational company and we are an organization headquartered in London, the UK. Our company specializes in international consulting services for healthcare projects associated with healthcare. Our expertise lies in midwifery, OB/GYN services of global standards, IT counseling in healthcare, and so on. We offer midwifery, OB/GYN education globally, and midwifery services to clients from various countries. Offer training and certification to aspiring midwives, doctors, healthcare professionals, childbirth educators, and caregivers. Conduct workshops to generate awareness on the benefits of natural birth and midwifery. Support women empowerment and work tirelessly in all related fields to achieve our ultimate goal, the betterment and progress of mankind. Samco is our parent company, 23 years old, UK-based that has pioneered education and training in the field of midwifery. We are trained professionals and students from Europe, Asia, Middle East, and the US, UK, Africa, to name a few. The team consists of doctors, obstetrician, childbirth educator, aquafit trainers, senior consultant midwife from across the globe. Our vision is keeping with the SDGs, and we are committed to creating a workforce of well-trained medical professionals who can offer their services towards good health and well-being. We aim to empower women by spreading awareness through our campaign and training programs with allow for providing women healthcare and education from childhood to elderly age, take informed decisions while birthing, active involvement of the partner in the entire pregnancy and birthing process till postpartum, reproductive birth, and hygiene and skilling and self-employment. Our pedagogical team, the pedagogical team at Leila Excellence Center and SAMTCO is highly skilled with experience that range between 20 to 40 years. The team designs tailor-made training courses to suit the needs of the trainees and to ensure that upon successful completion of training, the students can be gainfully employed in the health sector within India and abroad. We have diverse group of highly qualified trainers, master and PhD, and gynecologists spread across UK, India, Canada, the USA, Brazil, Iran, KSA, and New Zealand, who all were versed with physical as well as virtual training. Our training programs are comprehensive and designed to meet the educational needs of today's world. We offer various customized courses and training from basic to advanced learning. And we from Leila Excellence Center have successfully trained 3,500 medical professionals globally and counting, and hope to see you in our future training as well. Today, we have a training with one of our LEC scientific board, Dr. Edson. Dr. Edson Borges de Souza, he is advisor OB/GYN in Sofia Foltman Hospital of Brazil. He is the chief of medical residency in OB and GYN for 10 years. Dr. de Souza was senior advisor for Health Ministry of Brazil and Pan American Health Organization. Dr. De Souza worked as advisor for JCIA, Japan International Cooperation Agency, from 2018 to 2022. He's a member of the board of MMS Modern Maternity Service System in China and now LEC Scientific Board. Welcome, everybody, and welcome, Dr. Edson. Please, over to you. Thank you.
Hello.
Thank you, Doctor. Hello, Doctor. Welcome.
Hello. Yes, I'm very glad for being here with you again. I live in Brazil, and now it's midday in Brazil, just before lunch. And now we have, yes, a cloudy day here. But I'm very happy to be here. But I have to apologize. I had understood that we should talk only about diagnosis and management of perineal tear, even because we have already talked or something about prevention in a previous session, and it should be too long if we had put together these two issues in a same class. But anyway, I can promise to you, if you want, we can do the prevention session again if necessary. But for today, we will talk only about a diagnosis and management of first and second degree tears. Because if we had to talk about third and fourth degree tears, yes, we should need another extra time, but yes, everything can be done.
Sure. Thank you so much, Doctor. So we welcome all of you attendees from 13 countries. We have attendees from US, UK, Canada, Jordan, Ethiopia, Ghana, South Africa, India, UAE, Kenya, Ireland, Brazil, Mexico, Doha, and Kuwait, and Iran. Welcome, everybody. So start, and hope to see all of you. Please turn on your camera during the class. Let's see your beautiful glowing face. And we promise you to have next class for your prevention, we will have next class about prevention of tears. Sure. Yes, Dr.
Okay. Well, then, as I've already said, for prevention, we should need an extra class, because for today we have 30 slides. Then the time a preview is about 40 minutes, 30 to 40 minutes. Well, our learning goals for today are to talk something about communication and information. What kind of perineal tear classification? We have 4 degrees, and mainly this is the main topic. What are the effects of different methods and materials for primary repair of first and second degree tears, and also episiotomies? Then we will talk about 3 different issues. The first one, suturing or not suturing vagina and perineal muscle, sutured but perineal skin left unsutured. And secondly, what kind of suturing materials? Standard, absorbable synthetic sutures, or catgut? Because catgut is a more traditional kind of material, and then we have sufficient evidence to show that absorbable synthetic sutures should be preferred. And then continuous sutures compared to interrupted sutures. And finally, we will talk about secondary suturing when we have a broken perineal wounds. And the management of third and fourth degree tears will not be discussed today. Well, why this issue is so important? First, more than 85% of women having a vaginal birth suffer some kind of perineal trauma. Secondly, spontaneous tears requiring suturing are estimated to occur in at least 1/3 of women in the UK and the US. And I think in every country, the rate may be the same. And third, because perineal trauma can lead to long-term physical and psychological problems. So this is why this issue is so important. And we have to start by a good communication and information. And first of all, I would like to put an issue for reflection. I've already seen many people or many professionals, nurses, midwives, and even doctors. When there is mainly a third or fourth degree tear, sometimes people try to blame the professionals for causing that kind of tears. This should not occur because we don't have to blame or to feel ashamed because an injury has happened. Because anyway, we have around 2 to 3% of third and fourth degree tears. And sometimes we cannot prevent them. We have to do what we have to apply all our skills to prevent them, but sometimes we can't prevent. Then we have to, anyway, we have to reflection, there must be self-reflection. Are we good enough with our diagnosis skills? Because if we can't, if we couldn't prevent them, at least we have to make a right diagnosis and to do the right treatment, because this is what we can do. What we have the same reflections if it were about men's health. What will happen when we are not attentive enough? And this is a problem. And how can we improve? Then this is the kind of thing we have to think about, not to blame or not to be to feel ashamed because mainly a severe tear occurred. This slide has so many information, but let's fix on the red words because there are many informations, but I put it here because indeed all these informations are very important, but at least let's focus on the red words. To nurse the newborn baby, we have to arrange things to allow the woman to nurse or to breastfeed the baby. Secondly, good eye contact. That means good information. Sometimes touch the woman, a soft touch, and to calm and to explain to the woman what happened. And allow the partner or an assistant to provide emotional support. Let the woman in a very comfortable position. She should be well reclined and very comfortably positioned, as relaxed as possible. And for the professional who will assess and who will treat the tear, if there are tears, a good lighting from behind to ensure optimal conditions for suturing. And ensure that the woman remains in this position only for as long as necessary. If you have to interrupt her treatment, sometimes we have to do it, offer the woman the chance to place the legs together for a while. Then these are very important things. And if childbirth has happened in a home delivery or a birthing clinic, the woman can support feet on a chair or footstool. Anyway, there are ways to make a good position, both for the woman and for the professional. Then, second point is about diagnosis and classification of perineal tear. We have a classification that is used, I think, in many countries. This classification has been used since 1999. It was proposed by Souza. It is an English obstetrician, and he classified perineal tears in 4 degrees. The first degree is an injury that is limited to perineal skin only. A second degree is an injury to perineum involving perineal muscles, but not involving anal sphincter. And a third degree, we have 3 classes of third-degree perineal tears. It is an injury to perineum involving anal sphincter complex, and the third degree A, it affects less than 50% of external anal sphincter thickness TOR. Third degree B, when we have more than 50% of external anal sphincter thickness TOR. And third degree C, when we have both external and internal anal sphincter TOR. And finally, fourth degree, when we have an injury to perineum involving anal sphincter complex and anal epithelium. Then, as long as I know, this classification is adopted by the UK guidelines and also by the ACOG guideline. It's both of them are very up to date. The first one 2015 and the ACOG from 2018. These are the most up-to-date guidelines. Well, sometimes there are some doubts about classification when we have periclitoral, periurethral, and labial lacerations, because these are sometimes classified as a first degree, but indeed they are specific kind of lacerations. They are periclitoral, periurethral, and labial lacerations. Well, although we don't need to suture first degree lacerations, many times we have to suture this kind of lacerations in order not to have anatomic problems in the future. So, when we have small tears of anterior vaginal wall and labia, and they are relatively common, if they are superficial with no bleeding, they can be left unrepaired. One randomized controlled trial, including 80 women, it's too few, noted no differences in healing of minor lacerations of the labia, whether the lacerations were sutured or left to heal spontaneously. But expert opinion is to repair periclitoral, periurethral, and labial lacerations that are bleeding or if they distort anatomy. Then I think these here are some examples of this kind of lacerations. We have 2 specific lacerations in vulvar, vaginal, and cervical lacerations. Also, if we don't have bleeding or distortion of anatomy, vulvar, vaginal, or cervical lacerations usually are not repaired. But we have no data on which to recommend a specific practice for closure of this kind of lacerations. The repair of vulvar or vaginal laceration is the same, similar to that of first degree and second degree perineal lacerations. But if we have a cervical lacerations and if it needs repair, we have to use a running locking suture or even interrupted suture that incorporates the underlying tissue to restore normal anatomy. Then this is a kind of the recommendation. But the more difficult diagnosis is sometimes to differentiate a second from a third degree perineal tear. We have to know the definition very well in order to, we have to search it because it's very important to differentiate these two kinds or these two classifications of perineal tear. We have to note that a third degree tear is classified as involving the laceration of the following tissues. First, vaginal epithelium, perineal skin, and mainly perineal body, and the anal sphincter, the muscle that controls the anus. Well, we have to know that the perineal body lies directly underneath the layer of squamous epithelium and vaginal mucosa. It is a triangular in shape and is the joint connection between bulbar spongiosus and superficial transverse perineal and anal sphincter muscles. It is placed, we can see it just here. Here is the anus mucosa, and perineal body is just here. It lies directly underneath the layer of vaginal mucosa, and it's a triangular shape. And anal sphincter consists of two separate muscles, and it is formed by the internal and external anal sphincter. Yes, when we have a figure, it's easy to see. But when we are in front of the patient, it's not always easy to see it. Then you have to be very attentive. I think the tip is to search for perineal body. And if we see this lining of anal mucosa, we have to think in a third or even a fourth degree tear. Sometimes it's not easy to see the ends of external anal sphincter. It's easy to see it in a figure like that. It's located here, but it's not easy to see it here in the living patient. But how to differentiate it, a second for a third degree, and how to classify it? If you are in doubt, you should adopt the higher degree because it's always better. If you are in doubt, you should do at least two things. The first one is to call for help, sometimes to call for a more experienced colleague in your team. And if you are in doubt, adopt a higher degree, because sometimes we cannot differentiate easily a third degree, for example, a third B from a third A. It's not easy. If you are in doubt, classify it as a third B, because this is a very worrying issue. This is a lawyer office, and there are a lot of cases that that goes to the tribunals because some people search for compensation, and One of the reasons is the bad management of third and fourth degree tears. Then we have to be very attentive. Today, we will not talk about the treatment of third and fourth degree tears, but you will have to be very attentive about it. Well, let's talk about the effects of different methods and materials for primary repair of first and second degree tears and episiotomies. Perineal suturing 100 years ago, I think many things changed. 100 years ago, they used only this kind of interrupted sutures, and we have only this kind of materials. I don't know if they exist anymore. Silkworm gut, I've never seen this kind of material, or silver wire. And they, yes, we have yet the catgut in many places in the world. When I was a resident, we used a catgut here in Brazil. But nowadays, I don't think yes, some place still use it, but it's a very old kind of material. But this was the kind of suture we used 100 years ago. And in that time, there were no study, no trial comparing different kinds of suturing materials and different kind of suturing techniques. And nowadays, we have some kind of studies. And the first one, or the first question, is about suturing or not. What kind of perineal tears should be sutured, or what kinds of perineal tears should not be sutured? We know that if we have a first degree, and if it not distort anatomy, and if there is no bleeding, we don't have to suture it. But when we have a second degree tears, they have already compared leaving perineal skin unsutured but opposed with the vagina and perineal muscles sutured, then a two-stage repair. It may be more effective than conventional repair, in which all three layers are sutured, at decreasing the proportion of women with dyspareunia at 3 months, and at reducing perineal pain from 14 days to 6 weeks postpartum, but not at 3 months. But we don't know how they compare in the longer term. And we don't know how effective in reducing analgesic use postpartum. So there is some evidence of benefit associated with leaving the perineal skin unsutured compared with skin sutured in terms of reducing pain and dyspareunia. However, there are no long-term follow-up studies, and practitioners must be aware that with non-suturing, there is an increased risk of wound gaping that may be unacceptable to women themselves in the months and years to come. Then you have to individualize this case. There are some advantages, but we don't know how are the long-term results. This is the first question. So we should suture perineal muscles, and if skin is well opposed, I think there is a microphone open. Hello? Yes. Then this is a kind of suture. We should suture muscles, but we should leave skin unsutured if it is well opposed. Yes. Hello. The second question is about the kind of synthetic sutures, and they compared absorbable, and here I have this kind of absorbable suture is polyglycolic acid. It's the most used kind of material for suturing. And when compared with catgut, standard synthetic sutures were associated with less pain up to 3 days after delivery, less analgesia up to 10 days postpartum, and more women with catgut sutures requiring resuturing. This is very rare outcome to need a resuturing. It was more probable with a catgut, but it's very rare. And more women with standard synthetic sutures required the removal of unabsorbed suture material. So, conclusion, catgut may increase short-term pain compared with synthetic sutures. So, we should prefer this kind of material, polyglycolic acid and absorbable synthetic suture. And when they compared two kinds of absorbable synthetic suture, they compared a standard synthetic with a rapidly absorbing sutures. And short and long-term pain were similar. In one trial, fewer women with rapidly absorbing sutures reporting analgesics at 10 days, and more women in the standard synthetic suture group required removal. And there was no evidence of significant differences between groups for long-term pain at 3 or at 6 to 12 months. And nowadays, I don't know if you have been using this kind of glue because it was already tested. In our hospital, we don't use this kind of glue, but it was associated with shorter procedure, less need for local anesthetic, less pain, and greater satisfaction. So the use of this kind of glue achieves cosmetic and functional results equal to traditional suturing and offers immediate advantage for the patient. But anyway, there are a need of more clinical trials to validate these kind of results. And I think there are more trials that have been already done. But now we will talk about the two kind of sutures, and I think we have to put our hands on, because traditionally, or traditional books or the ancient books recommended the interrupted perineal repair, even with a standard or a rapidly absorbed sutures or a catgut. When I was a resident, one time I made a continual suture, and I was blamed by my boss. I remember it occurred more than 20 years ago, and I remember it until today. My boss blamed me. He said, you should never do this kind of continuous suture to repair a perineal tear. But nowadays, we have sufficient evidence, and this is a Cochrane review. They included 16 studies from 8 countries. And the conclusions were that continuous suture techniques, including all layers, or perineal skin only were associated with less pain for up to 10 days postpartum, overall reduction in analgesia, reduction in suture removal, and no significant differences in the need for resuturing or long-term pain. So this kind of suture should be preferred. And Lily, will we put our hands on now?
Yes, sir. If you want to keep session open for question and answer session, sir, doctor?
Yes, let me only to add some informations.
Sure.
The current ACO guidelines recommend continuous suturing for the repair of episiotomies and second and first degree perineal lacerations. However, when these guidelines were issued, it was unclear if continuous suturing was associated with reduced postpartum dyspareunia. But there was a review last year, and they concluded that there is no significant difference following continuous or interrupted perineal repair. And I would like to talk about this publication too, because it's from Iran, and they arrived to the same conclusion. Maybe some of you should know them. And then the conclusions are exactly the same. Continuous non-locking suture was associated with reduced perineal pain and improved wound healing, shorter duration of perineal repair, less suture material use, and this is a very important advantage too, and less need for analgesics. So I think many advantages. And before putting our hands on, it's important to mention too, this kind of inverted suture, are they continuous or interrupted? And I think we can practice both interrupted suture, but we have already to admit that this is not our first choice anymore, the interrupted suture. Both ACOG and both in the UK and the Cochrane reviews, there is a very strong conclusions that continuous suture are preferred, and when we compare it with interrupted sutures. So, well, then we have here an absorbable synthetic material suture. Oh, let's cut it. Okay. Then this
Doctor,
is
yeah.
yes.
Can you please, I thought you want to show your desk. That's why it's not showing well. Can you please set up your camera
Yes,
to show you are doing some, suturing, please. Thank you.
I will change it.
Thank you. Wonderful.
Maybe I will need some
So
support.
everyone, please look at Dr. Edson, and at the end of the session, we want you to try in front of us with your camera on. We will observe how you performing your suturing. Please look at Dr. Edson, and at the end of session, we will go on with our hands-on training. Thank you.
Yes, you can see? Wow.
Yes, doctor.
And here, let's think we have second or a first degree perineal tear? Well, we will begin from inside, from the vaginal mucosa, because we have to begin from the mucosa. So we have to find the distal angle. And now we have to use, I'm using an absorbable synthetic suture. Usually we have to use.
Doctor, can you close this presentation so that everybody sees you?
Okay.
Till the time you're.
I did pin
Yes.
Dr. Edson. I made Dr. Edson pin.
And maybe later I will have to come back to the presentation for the final words.
That's wonderful,
But-
Doctor. It's good. Now I can see. Yeah.
Okay.
Yeah. It's more practical now. Thank you.
Yes. Yes. Then here we have the distal angle of vaginal mucosa. And we need a good lighting and a good light to, we have to see it clearly. If we cannot expose, we have to call for help for another person to help with exposition. We have to see it clearly. Sometimes there are some people recommend using a tampon, a gauze tampon, because there are always some bleeding. And if we have bleeding, we have to dry it many times. We have to take care not to forget this gauze tampon inside the vagina, because this should be something unacceptable. We should not forget this kind of material inside the vagina. Well, then let's begin. This is a kind of, we start from outside. Well, we could make interrupted sutures if we make a knot just now. Yes, this is a kind of interrupted. For each stitch, for this kind of absorbable sutures, we need around 4 to 5 knots.
We need you to, put down the camera a little bit, so that we can see. A little bit down.
Yes. Let me put another hook here. Oh, sure, that's right. Oh, here. Well, when we do a continuous, if we have interrupt, we should cut it now. We cut and we make again another. The distance between these two stitches is around 1 centimeter. 0.5 to 1 centimeters. It depends. If you have bleeding, it should be closer. If we don't have bleeding, oh, well. Well, this is a kind of interrupted. When we have two interrupted stitches. But let's remember, I've said that interrupted, which is the difference between interrupted and continuous suturing? Can I ask for the students? You can tell me.
Who is the smartest student of today? Who wants to answer? The smartest student of today.
Yes. They can tell or they can write here in the.
You can write in the
meeting.
chat box.
Yes.
So interrupted
Because-
suture. Hi.
Okay.
So interrupted sutures, you're gonna do each stitch separately and tie it
Yes.
off. Whereas with a continuous suture, you're going to start it, tie it, and continue with the same material until you're done or run out of material.
Yes, Amanda, good.
Bravo.
And which are the differences? The difference when why are continuous suturing preferred, or why they are judged better than unsutured sutures?
They use less material, they result in less pain, less trauma. They tend to be more comfortable, they absorb better when they're continuous.
Yes. Yes, there should be one kind of worrying. Some people believe that continuous should be worst, because if we have if the stitch breaks down, then we should have the dehiscence, but this didn't happen anyway. So we should not be worried about this kind of complication. So we will not use this kind of stitching. Let's begin. So we prefer continuous. And if we adopt a continuous suturing, we can begin our suturing from outside. Okay, from outside. Well, we can begin from outside. Oh, we can begin it from outside. Oh. 1, 2, 3, 4. Yes. And now we don't cut the ends of our suture. We go. We go on. And yes, you can see our suture is not locked. What is a kind of locking? When we talk that when we say that we locked our suture, what's the meaning of locking? Do you know it?
Who is the next? Who wants to answer?
Yeah. Yes. This is a continuous non-locked suture. We don't lock. What should be a kind of locking suture? Well, I will show you.
Yes.
Oh,
Yeah.
There's-
yeah, answering the question. Sorry, my internet is not so good. You basically, instead of not letting the sutures cross, you're coming back in between the two so that it holds them together.
Yes, sometimes
So-
I think it's not easy to explain without having
No.
the materials. I don't know if you
but
can
it does
see
hold them tighter.
that there is a difference, a small difference. You can see that our suturing material. Let me see it again. Here, let me undo it. Yes, here it's not locked. Okay. Now I will lock it. Okay, you can see we don't need to lock this suture unless we have bleeding. If we have bleeding, to lock the suture should be better because we can stop bleeding through locking. But usually we can stop bleeding even if we don't lock it. So suture can be done without locking. It's easier. Yes, it's very easier. And I think we don't, it's easier and it's easier to do. But there is still another way to do things. Hello?
Can you, would you mind showing for the younger students and whatnot, showing the locking suture again with a description what you're doing? Because I think that, is that called a blanket stitch when you're sewing? But anyway, I think that if you can explain it by showing it slowly, it will help the ones that are learning from the very beginning. That would be great.
Okay, I will do it.
You're making some really good points. Like if it's, if they're bleeding, then you want a blanket stitch or you want a locking stitch. You're making
show
good
it again?
points. Yes, you mind and explaining it slowly so you can show them what it actually entails.
Yes. I think I will change the banana for an orange. I think it should be better. Just 1 minute.
You can try with some other instrument at home with a piece of sponge or with chicken leg. So just now you observe Dr. Edson and try by your own at home as well.
Well, let me show you. And now I will begin my suture from inside. From inside. You can begin from outside, okay? But you can begin it from inside. From inside. Well, what is the advantage of beginning it from inside? The knot will be hidden inside tissue. And sometimes this is small knot, it is painful. And if you can put it hidden inside tissue, you will see, you will not see this knot. So let me fix it. It is totally hidden. Wow. You can see now, there is no knot. If you, it is smooth, there is no knot. So this knot, this small knot, will not cause pain or cause discomfort for the woman. So there is advantage of putting the knot inside tissue. Put it hidden inside tissue. So after doing this first knot, you can continue your suturing. The next one began from inside. So let's go. From inside. Oh, okay. I think you can see it. There is no knot here. If you put the tip of your finger, there is no knot. Then this is better for the one. And then let's go our unlocked continuous suturing. Okay. I will show you how to do a locking or a locked suture now. Well, look at my suture. Look at the tip of the needle. The tip of the needle is here. Here is my suture. Here is the tip of the needle. If you put the suture inside, you will not lock. But if you put it outside, you will lock it. Well, can you see the difference? Let me see. Let me do it again.
Thank you. This is very good.
Very good.
Yes.
Then this is the tip. Let me do it again. One more stitch. So here is the tip of my needle. Here is my suture. If I put it inside, it will be not locked. But if I put it outside, it will be locked. Okay? If I put it inside, not locked. Outside, locked. So, yes. Then this is the preferred, this is the recommended technique for suturing perineal first and second degree tear. And now I will go back to my presentation.
Can I ask a quick question?
Yes.
Thank you. In the presence of bleeding, would you say that you would then make the entire repair with locking sutures, or would you only lock the sutures that are in kind of localized in the place of bleeding? Or would you just say, this is a bleeding wound, I'm going to lock all of them, or only some? How would you make that call?
No, you can do, you can lock just in the point you have a bleeding. If you have a bleeding point, you can lock just that one. Okay. This should be a mixed technique, but there is no problem. Although this is, I have to recognize that this is a kind of experience, because when they compare the techniques, they don't measure it this kind of detail. So yes, you can do, you can lock just one stitch, no problem, no problem. You can do it just both for the mucosa and for perineal skin too. You have, anyway, you have, when you finish vagina mucosa, you have to finish the suture, and then you look if you have muscle, Sometimes for muscle, you have to do interrupted suture. Okay, this kind of continuous is just for mucosa and for skin. But if you have to suture the muscle, then you should be non-interrupted sutures.
Mhm.
Okay, let me see. So here are our conclusions. We have evidence that are beneficial. The use of absorbable synthetic sutures for perineal repair of first and second degree tears and episiotomies. And we have evidence of beneficial for continuous sutures compared to interrupted sutures. It's likely to be beneficial when we let vagina and perineal muscle sutured, but perineal skin left unsutured in first or second degree tears and episiotomies. This is likely to be beneficial, but we have to admit that we don't have long-term outcomes. We don't know how are they. And is likely to be ineffective or harmful, non-suturing all layers in first and second degree perineal tears, mainly when we have bleeding or when we have distortion of anatomy. And finally, this is my last slide. Sometimes we have a broken down perineal wound, and this is a very uncomfortable problem because traditionally these kind of wounds were left to heal spontaneously. People believed that resuturing these kind of wounds would be not good because of infection. And indeed, we have just one Cochrane review almost 10 years ago, and they found just 2 small studies of poor methodological quality, only 52 women with dehisced and or infected episiotomy wound. And at that time, there was no evidence available to either support or refute secondary suturing for the management of this kind of broken perineal wounds following childbirth. So they recommended people had to do another randomized controlled trials to compare these 2 kind of options. But nowadays, we already have some studies, and if we have a perineal broken wound, if there is no infection, maybe it's better to make an immediate resuturing because it would be better for a more rapid healing and more comfortable for the woman too. But I remember 20 years ago when I was a resident, there was a woman with a broken down episiotomy wound, and my boss don't allowed me to resuture it, and it was left open until spontaneous healing. I don't believe we have to do this kind of management anymore. So this, I think this was my class for today. Thank you, Lily.
Thank you so much, Doctor. It was a very wonderful session. And I love to hear from attendees. If you have any question, any doubt, any suggestion, and please share with us. I would be happy to hear from you. Okay. Anybody
Hello,
wants?
Lily. Today we had I think there are, these are very simple information, but I think until in Brazil, there are many people that still believe we have to do interrupted stitches, interrupted suture, and this is not true. We can do continual suture. Absorbable synthetic material is better, no doubt, and we can hidden the first knot. We can hidden it through entering to starting our suture from inside and putting the knot hidden inside the tissue. But vaginal mucosa or perineal skin.
Yes, good point. Okay, anybody wants to add?
I do have a question
Sure.
about adhesive glue. Have you ever used the adhesive glue in a perineal tear, first degree? And if so, what were the results?
No, in our hospital, we don't have this kind of glue, so I have no experience with glue. But there are more studies, and it looks it's similar to the continual suturing. If you have access to this kind of glue, I think you should use it. But I have no personal experience.
Thank you.
Unfortunately, thank you.
Any more question? I'm sure most of you have this pad for suturing. If you have it with yourself, or you have this kind of training material, you can try now. Turn on your camera and we will see how you are performing. Who wants to do? If you have some needle, or if you have your instrument, you can try now. Anybody wants to try? Okay, anybody? Yes, Midon, very good. Let's see. Who else? Let's see, I see who's doing. Very good, great. Doctor, you can see Midon? Can you see Midon? Yes. Yes, Jan, please. You have question? Jan
Yes.
Kinko. Yes, sure, please.
Hi, doctor. Hi, everyone.
Hi.
Good afternoon. I'm dialing in from Cameroon in Africa. That's Central Africa. I'm so happy. I loved the presentation. Thank you so much. I have one question for the doctor for his lovely presentation. There is this school of thought in the midwifery practice in my part of the world that at times suggests that since first degree perineal tears are skin tears, we can leave it unrepaired. I don't know what the doctor's advice on this practice is.
Excuse me, you are talking about what kind of third degree? First?
First. Yes, doctor,
yes,
first.
First. Yes, a first degree, you can left them unsuturated, unrepaired, if they are not bleeding, and if there is no distortion of anatomy. So you can left them unrepaired, mainly if they are from vaginal walls. But if you have periclitoral or of labia often there is some distortion of anatomy. So you have to take care about it, because this should be very disturbing for the woman in the future if you left this kind of anatomy distortion. But if there is no distortion, or if there is no bleeding, then you can leave them unrepaired, no problem.
All right, doctor, thank you very much.
Thank you.
That leads me to my second question, if you permit.
Yes.
I wanted to ask about the post-suturing management for perineal tears. We do encourage sit bath. In this our part of the world. We use the table salt, that's saline. We mimic the saline solution, normal saline solution for women to do sit bath, or they use the gynecological betadine to do sit bath. And then my question is, among these two practices, using salt, using betadine for sit bath, should we encourage which of them? And also, should we manage these cases with antibiotics? Should perineal tears, first, second degree perineal tears, also go along with oral antibiotics?
Can you write here the name of the solution? I didn't understood it.
Betadine, doctor. This is betadine.
Betadine?
Yes, doctor. Yes, Jan, is
Betadine.
it correct? Am I get right? Betadine.
Betadine.
Oh, yes.
Povidone iodine,
Betadine.
right? Povidone iodine.
Yes.
Yes, yes.
Yes, that is povidone iodine.
Yes.
Ah, povidone.
Good
Okay,
question.
okay,
Very
okay.
good point
Yes.
you mentioned, Jan. Bravo. It is happening
Yes,
even in
okay.
other countries, Asian countries as well. Yeah.
Yes,
Yeah.
now I understood clearly. Okay, let me, I have to share one more slide here.
Great job, Amanda. Great job, Midon. I see how lovely you are doing your job. Great, great. Bravo. I love you, active and dynamic student and girl. Good midwife. Bravo.
Yes, they are doing very good.
I love these hard workers. You have reward. Another
Yes.
free session for you guys, active students.
I will answer this question because we have some interventions for perineal pain after childbirth. Are them repaired or not? Because there are some evidence about this. They have already studied topically applied local anesthetics, and there the evidence for effectiveness of topically applied local anesthetics for treating perineal pain is not compelling. It's not good. There is no evidence that we need this kind of treatment. Cooling treatments, they have already tried it too. And there is limited, very low certainty evidence that may support the use of cooling treatments in the form of ice packs, cold gel pads for the relief of perineal pain in the first 2 days following childbirth. And they tried the use of non-steroidal analgesics in NSAIDs. And this is this kind of treatment may provide greater pain relief for acute postpartum perineal pain, and fewer women will need additional painkiller. So it can be used. It can be used. And the paracetamol to a single dose may improve perineal pain relief following vaginal birth. but I didn't found any kind of Cochrane review about this kind of povidone. Yes. Let me see here. Yes, this kind of betadine. No, I didn't find any Cochrane review talking about betadine or this kind of povidone. No, we don't know.
Okay.
In Brazil, we don't use it. We give orientations to the woman to let the wound clean with
Okay.
clean water. It's enough.
Okay.
Doctor, there is
Okay.
some notes in the chat box. Actually, Thalys is appreciating Midon, look great, Midon, and Juliet De Womo, she's written in Ghana. Okay, in Ghana, sitz bath is encouraged with either Savlon solution or sea salt or povidone iodine. Use of antibiotics, mostly metronidazole and amoxicillin. And we have from Nivedita, she's written antibiotics are not given now for normal birth.
Yes, antibiotics, we don't need them.
Yes.
We need antibiotics just for as prophylactic measure when we have third or fourth degree. But for first and second degree, we don't need any kind of antibiotics.
Yes, and
Okay.
we have from Thalys, she's mentioned arnica gel works great for the pain. Arnica gel. Rachel mentioned, will there be another way to show suturing for the certificate? I have a mom about to push and would love to finish this later. Don't worry, Rachel. We take care of you. And one more question. Any more question? Any more comment in the chat box? Any more questions?
Hi, Dr. Leila. I would just take a minute.
Yeah, sure.
We are celebrating the International Day of Midwives on 5th of May at the same time, 9 p.m. IST. I would request everyone to register yourself on the link I've just shared, and we would, send out a participation certificate for all the midwives and whosoever joins for that particular day. And also, I would request you all to send an email with your complete name to receive the certificates for this particular course. You can, send an email at info@lilymcenter.com or
Your voice
the number
is
which is there.
disconnected.
And on the link.
Mr.
And
Sayed,
nobody,
your voice is
no
disconnected.
worries if someone is in a rush and somebody says she has a mother to attend, she can just move out and she can send an email with her name and we would provide the certificate. Thank you so much to all of you.
Thank you so much, Mr.
Thank
Sayed.
you so much.
Midwife Carol is written, caution with iodine. Some are significantly allergic to povidone iodine. Nuri seaweed is effective at holding together first degree tears. And thank you so much. Dr. Edson mentioned to everybody, yes, Carol, we need to talk about prevention. Of course, don't worry. We have another session. So, any more questions? Who else wants to show her hands-on performance? Oh, Jade, go on. Let's see.
Very good. Yes.
Oh
These,
my God,
I can
lovely.
see, but these are continuous suturing. Yes.
You can explain, Jade. days.
Yeah, one side is interrupted suture and the other is continuous. So I started with interrupted and then finished with the continuous. Just to practice.
Great, great. Dr. Edson?
Well, yes, I think there, Carol talked about the prevention class. Yes, this I have to apologize to you, but I hope you can understand me, because if we had to talk about prevention, we should spend another hour, and we could not talk about our program today. But I promise to you, if Lily is agree with that, we can do another session about prevention,
Sure, sir.
because it's very important indeed.
Sure, sure. And we have International Day of Midwife. Maybe we can keep it as a gift for all of attendees for that special day in next, I think, 6 days, 5th of May.
Yes, congratulations for
Okay.
every midwife. Midwives are essential, are very important all over the world, and we need much and much more midwives inside hospitals and working in the community in order to achieve better results for maternity care. This is a universal truth. We need you.
Thank you, doctor. So for 5th of May, let's celebrate International Day of Midwife with a gift from Dr. Edson for all of you about suturing techniques. And we have another special training in that day with one of our experts with more than 40 years in midwifery about holistic midwifery. So don't forget to join us for 5th of May, same time, and register just now. Midwife Carol written Cinco de Mayo. I don't know what does it mean. Cinco de Mayo, sir. I don't understand what is that.
Cinco de Mayo, it's my 5th Spanish. Are you
Oh,
Spanish, Carol?
and Talis is written, I will have a banana or orange next time. The sponge wasn't good. Sure, Talis. So next time, next week, in this time, don't forget, bring your banana or your orange or a piece of chicken leg. Then if you have, bring with your.
You're not audible.
There is some.
Carol is asking who is going to be teaching holistic midwifery. We would have Irene, I guess. And
Yes, Irene and Gail are talking.
Gail
Are going to
Johnson.
talk. Yes. Cinco de Mayo in 5th of May holiday. I don't understand what does it mean. USA and Mexico a holiday. Am I audible now?
Yes, you are.
So we learned Cinco de Mayo. Okay, good. Oh, am I audible now? Sure. So we are going to have another session as a physical training in India with Dr. Edson in July 2023. It will be 40 hours advanced midwifery and obstetric. So you can join us in our physical training in India and spend time with too much attraction in India and spend time with Dr. Edson in person and have a physical class.
Yes, it will be wonderful, Lily.
Yes, one
My
week
heart
altogether.
it's already beating.
We are ready, and I hope we see all of these beautiful attendees there. Please welcome to India, July 2022.
Yes, I think it will be a very beautiful and very important meeting, and we will can exchange or share knowledge and experiences, and I think it will be wonderful.
Yeah.
The
Yes.
link I just shared, is for the center we have for this training in July. You can all watch it if you would like to. And previously, I've shared a link for the registration on 5th of May for International Day of Midwives. So we'd request everyone whosoever is interested and free on that particular day can register right away and, be present on 5th of May. You can also share this with your colleagues and friends so that we have more people joining us for the celebration.
Yes, we would love to see you all in 5th of May and with our special training. And in July in India, and even in August, we have a midwifery internship in Perth in Georgia as well. So please join us and continue, stay with us. We will have another session next week, and every month we have one special midwifery training for all of OB/GYN midwives from different parts of the world. Till now, we train 3,500 midwives and doctors from different parts of the world, and we want to continue with our fantastic expert trainers like Dr. Edson and entire our special team. So please, if you want to get your certificate, don't forget to send your full name to our email address info@lilymcenter.com. Then you will receive your certificate within 1 week. For Persian language attendees, دوستان عزیز ایرانی که شرکت کردن، ترجمه این کلاس براتون ضبط میشه، براتون دوباره لینکش در یوتیوب گذاشته میشه و میتونید بعداً ببینید، نگران ترجمه نباشید. I'm so sorry I'm talking into language. So if you have any more questions, suggestions and feedback, please don't forget and please write and mention in the chat box. We will be happy to hear from you. Thank you so much. I think we can wrap up the session, and let's see. Yeah, chat box, there's nothing in chat box. Can you please turn on your camera and let's have one photo together as a memory for this special day. Thank you so much, Dr. Edson. Thank you.
Thank you
Amanda,
very much.
Ariana, and who were very active in the class. I forgot the names. Jade and wonderful Carol, thank you for your very wonderful performance. Next time, don't bring banana, orange, chicken leg, or any other suturing material. Bring with yourself. Let's have more productive and effective session. Okay, we are here with you. We want to stay with you and continue developing and upskilling ourselves together. Thank you so much. Please turn on your cameras. I'm waiting. Jay, Banin, Fateme, Haya, Tarub, Nicole, Fateme, Khawla, Carol, Azadeh, and thank you so much, all of attendees from 13 countries. Again, I say thanks to all of you. From US, UK, Canada, Jordan, Ethiopia, Ghana, South Africa, India, UAE, Kenya, Ireland, Brazil, Mexico, Doha, and Kuwait, and Iran as well. Thank you. Thank you so much. A smile. Let's see your beautiful smiling face. Don't forget 5th of May, 9 p.m. IST, the same time. We are waiting to see you. Love you.
Bye. Bye
Thank
bye
you
bye.
so much. Thank you.
Thank you.
Love you, everybody. Thank you so much. Take care. See you soon.